I'm being joined on the chat feature by my colleague Tal Bowie, who's joining us from New York. My name is Eric Valera, and I am coming to you from North Carolina, where we are the Latino Commission on AIDS. And the Latino Commission on AIDS is a national, regional, and local community-based organization headquartered in New York. We're a national capacity building assistance provider. We do capacity building assistance in 2 areas. Our first area is Hands United, which focuses on capacity building assistance for community-based organizations. And our other one is Healthy Communities Now, or Comunidades Saludables Ahora, which focuses on community mobilization and building capacity for communities. And so we are proud to bring this webinar series to those who are interested in learning how to advance in the field. Just some housekeeping. We're going to be muting the lines as needed, and you may also use the text feature on the side if you have any questions, and Tal will be answering your questions and be able to share them with us as well. And if you can also have a feature there where you would be able to raise your hand if you would like to stop and ask a question. And towards the end, if anybody has questions, we'll continue. We'll be able to ask of our guests live. Now, a little bit of background on the purpose of doing this series of webinars. The CDC has provided guidance for program collaboration and service integration for HIV prevention and care. They refer to this as PICSI. And the reason behind this is so that we're not replicating services and so that we're integrating them in a meaningful way. And electronic health records are a key part of that. So for program collaboration and service integration, the working definition that the CDC provides us is that it's a device for organizing and blending interrelated health issues, activities, and prevention strategies to facilitate comprehensive delivery of services. As we know, a lot of our organizations provide many different types of services, and there's different types of services that exist in our communities. Integrating these services, organizing and blending them in a way that is able to help that client be able to access these services and for service providers to be able to learn from each other's experience with that client provides that client a better way to be able to better services, better quality of services, as well as it also allows the organizations to be able to become more efficient in the way that they do their work. So the goal of PICSI, as it's called, is to provide prevention services that are holistic, evidence-based, comprehensive, and high quality to appropriate populations at every interaction of the healthcare system. And as we're moving forward with the high impact prevention in the national HIV/AIDS strategy, it becomes more important to provide higher quality of care while at the same time being able to reduce costs and being efficient and being very considerate of our organization's sustainability. So some of the principles that the CDC gives us in guiding us is that the program collaboration and service integration needs to be appropriate. Not all services apply to everyone. They need to be effective, and you should monitor their effectiveness. They need to be flexible, and we need to be ready to respond to changes as they need to occur. Accountability is important. Continuous feedback facilitates this process of improvement, and acceptability. It needs to be accepted by staff, providers, and those who are consumers. So these types of services can look, these type of integration, program collaboration and service integration can take many different forms. But in this one, we're going to be focusing, for this series, we're going to be focusing on the electronic health records and how those, and the electronic health records as the cornerstone of program collaboration and service integration. So I'd like to introduce our guests today. We have with us Anna Worth, and Anna Worth is the Director of Healthcare Operations at AIDS Resource Center, Ohio. And she's a licensed independent social worker. She's been with the organization for over 7 years, which time she has worked as a medical case manager, managed the HIV prevention programs, directed the Ryan White Part C grant, and now oversees operations of the ARC Ohio Medical Center. She's been heavily involved in opening the organization's first medical center and pharmacy in 2012, and was a key member of the Electronic Health Records Implementation Team. Anna recently presented a seminar at the 2013 U.S. Conference on AIDS about the process of opening this facility, wrapping up their first year of operations. The organization is now beginning the process of transitioning to a new electronic health record system, and we're really excited to have you and to learn more about this experience. Also with us is Catherine St. Paul. Catherine St. Paul is the Billing Compliance Manager. Ms. St. Paul is a certified coder and member of the AAPC, as well as the NRHC. Catherine has 10 years of coding experience, including medical and dental coding. She's been an active compliance manager for 7 years and developed compliance programs for several providers in the New Orleans area. Catherine has been with No AIDS Task Force since September of 2007. She's assisted the agency in selecting the electronic health records and PM programs that are currently in place. Catherine has been responsible for credentialing and managing care contracts. She's developed the billing department as well as the HIPAA, the OIG, and the OSHA compliance programs at the agency. And she's also being joined by her colleague Jack Milloway, who is the Quality Improvement Coordinator. Jack is responsible for a lot of the day-to-day data reporting and electronic health records customization. So we're thrilled to have you all with us. Thank you so much for joining us.
Thank you. Thanks.
So I'd like to begin with you, Anna, and perhaps you can tell us a bit about your experience and what is your role. Explain a little bit on what your role is at ARC Ohio and how how it is that you came to work with the electronic health records.
Sure. About a year and a half ago, perhaps 2 years ago at this point, our organization decided that it was going to shift directions. Historically, we had been more of a traditional AIDS service organization, so we provided medical case management, some behavioral health services, support groups, a realm of prevention programs, including DEBIs, and a lot of HIV testing. But what we were lacking was a method to generate our own income. We were very reliant on private donations and grant funding. And with the kind of climate that we're in at this point with grants, we felt that we really needed to improve our sustainability if we wanted to continue providing HIV services in the future. So we made the shift to bringing in our own medical center and pharmacy. And the way that we've structured our program is probably similar to some other programs nationwide. We've got medical center, pharmacy, behavioral health, case management, some HIV testing, and other support services, all located at one site. And we're offering a very integrated, comprehensive approach to care. And so when we opened October 2012, a lot of my role was transitioning from running a Part C program that was primarily external to our organization to bringing that in and implementing it within our own medical setting. So I was heavily involved in kind of coordinating the medical providers, hiring staff. We really didn't have anything. We were starting from scratch as a clinic, so it entailed getting the proper licenses in place and creating exam rooms, for instance. And and so part of that process was selecting an electronic health record. That was a big part of our planning process, and one that I will say, looking back, we probably should have spent a little bit more time making that decision. We were moving very quickly with the implementation of our medical center and pharmacy. Our board voted to do this in February of 2012, and we opened October 2012. So we didn't have a lot of time to get everything in place. As we moved kind of fast-paced through this process, we interviewed several vendors of electronic health records, some of which were clearly more sophisticated and robust than others, but there were problematic timelines. Many of the systems that we wanted to use would not be available for at least 6 months out, and we needed it to be up and running within a 30-day, 60-day time frame. So much of what I was doing early on with the clinic entailed getting the electronic health record in place with the appropriate hardware, working with our billing specialists to ensure that all of the contracts with insurance companies were in place. As we got new staff on hand, new providers, we had to credential them and get their information in the system, and then go through an extensive training process. And as Eric mentioned, we are now looking to transition to a new electronic health record. Actually, in the coming months, we'll be making that transition, which we're really looking forward to, but is a huge and time-consuming project. So that's where we're at with our electronic health record. And I can go into more detail about some of the issues we've run into if you want me to, or I can hold off on that aspect of it for now.
Well, I would like you to bring that up, but before that, I would like perhaps to introduce Catherine and ask what her role is on the team, as well as Jack, and what their experience has been thus far at NoAIDS Task Force.
NoAIDS brought me on in 2007 to help them choose an electronic health record. At that point, I was a contract worker. I had several clients that I was working with in the New Orleans area, and we looked at several different programs and really were limited with the cost because the really good programs were cost prohibitive for us at that time. And the program we chose is a good program, although our providers don't always think so. And I'm sure at some point we will change. But I helped them choose the electronic health record, and then I helped them implement it. I did all the credentialing of the providers. I did all the payer contracts, and I set up all the billing. And up until, in 2010, I went full-time with NoAIDS. And up until about a year ago, I was doing it by myself. But we've grown so much, we now have a billing department. So that's been my part in it. Jack?
Hi, my name's Jack Milloway. I work in quality improvement at NoAIDS, and I've been at NoAIDS for about a year and a half. And a lot of what I do is doing a lot of since especially for Ryan White grantees, it's really data intensive and reporting intensive. So I've done a lot of the data reporting and figuring out how to get data out of the EHR, as well as doing a lot of EHR customization so that the doctors can see more of the stuff they want, and we can try and figure out how to make it the most user-friendly it can be.
Thank you. So I'm interested in both of your organizations have gone through transitions when it comes to the electronic health records. And I think an important aspect of this is the team that you guys have. You guys have a particular role in the team, but perhaps you can help us understand what other roles are important to bring into when it comes to choosing an electronic health record.
Oh, sure. What we've experienced is that having someone from all aspects of your organization is really critical. So once we've selected which vendors and which programs or systems we want to consider, we will set up demos with that vendor. And within that demo, we'll have the office manager. So I'll be in there. We'll have our billing specialist present, as well as one of our key providers who's a nurse practitioner, very familiar with the systems, and we'll have our medical director on hand. We've found that typically CEO level folks aren't always that interested in the details of the health record. They're more concerned with the contractual arrangements and some of the larger reporting capabilities. But they don't always need to be in the demo itself, as long as the rest of your team has good knowledge and experience with what they're viewing.
And in New Orleans, what aspects of the team, you guys have a bit of a different structure. As I understand, in New Orleans, I'm not sure how many different buildings you guys have. I've visited you guys once, and I know that there was a lot of your services are all in one building. And so, what aspects of the electronic health records what roles, who are the people who make up the team when it comes to choosing an electronic health record and implementing?
Well, I think I agree that it needs to be, we did not have this because we didn't really, this was back in 2007 and we really didn't have the staff that we have now, but I think you've got to have a mixture of IT, you've got to have billing, you've got to have whoever's going to do the insurance verification piece. You really have to get the people who are going to be working on it. To look at it and pick it out, and probably a couple of providers, a couple of nurses. This was so new to everybody at the agency that nobody really wanted to be a part of that team, but now I think everybody would jump at the chance to be a part of it.
That's fantastic. Do any of your organizations continue to use paper files, shadow files?
In Ohio, we do use some paper charting. Our organization is still rather segmented when it comes to the programs that we have and the systems that data is entered into. For instance, our case management program is in a separate database at this point. And with that, there is a paper chart that goes along with that case management record. And we're looking to integrate that in the future, but it is very challenging to find a system that meets the needs of both your case management program and the very detailed outcomes measurement that you're trying to do with that, and the health-related or health record and the billing system. So we're still working on that one. In terms of our medical record, virtually everything is electronic. We do keep some initial registration paperwork and a few signed forms on file, and that's kind of one of our backup methods so that we have something on our patients if our internet goes down or something along those lines. But we've virtually transitioned everything over to an electronic system.
And in New Orleans, do you guys still use paper at all?
We have some paper just because our providers, we're still in the process of getting them transferred over. We are using the electronic health record and billing electronically in the same system for our behavioral health, but we have a different system that we use for our case management.
Mm-hmm.
And how is case management? How is case management different from the rest of the services?
Well, we have not been billing case management through our software because the case management the services are entered into CareWare, which is our city system for Ryan White. But now with the new behavioral health plan, we're going to start billing for some of our housing services, and but those will be billed directly through Magellan. So we kind of have to use a combination of all these different kinds of software.
And just to kind of add to what Catherine's saying, and also just kind of expand on it, it's really difficult to find any software that's going to hit all of your needs. But we've had some success writing some grants not to get new software that is one-size-fits-all software, but we've built a lot of interfaces between our software and we're trying to just really stress interoperability between all of the softwares because it is so hard to find one software that does everything. So it seems like one of the better solutions might be trying to just make sure that all of your different systems can talk to one another.
That's a really good point.
And Anna, I think when we had spoken before, you had mentioned something similar about case management. Is that your experience?
Absolutely. It's been very challenging. I would say the way that we've tried to integrate our electronic records across programs is very much a log in, take a look, and retrieve the information you need, and basically copy it over into the other system as appropriate. It's a little archaic and clunky, but interfaces are a very real possibility for many of the systems that we're working in. And in fact, a lot of health records or case management systems can have interfaces created so that they're connecting with CareWare. And in terms of Ryan-White reporting, like they mentioned, that can be a huge time saver and really help with cleaning up data. But in terms of providing care on the spot, our staff are still kind of going back and forth from one system into another to verify things like income, to see if they're Ryan-White eligible, and that sort of thing. So not ideal yet, but I think it's always a work in progress. And as an administrator, I'm always looking for ways that I can reduce the duplicative efforts of my staff so they're not doing double data entry all the time, or triple data entry in some cases.
And maybe you guys can let us know, where is data stored? Is it stored on site? Is it stored on a cloud?
Our data is stored. We have a server at our office that stores our data. But that server we also back up remotely, and our remote server is out of the area. Since we live in New Orleans and hurricanes are always kind of a threat, we have an off-site data backup that's way out of the region.
In Columbus, our electronic health record is hosted off-site. The vendor hosts that server. And so our data is only accessible through the internet, through the cloud. So if the internet goes down, we're out of luck. We can't access the record. So there's a very real problem with that. However, if our facility was destroyed for whatever reason, we would be able to hop on a computer elsewhere and be able to retrieve that record no problem. So there are some benefits to that as well. When it comes to our organization's data, we do store that on a server internal to the organization, and then similarly back that up at like a mirrored server that's off-site, just to protect that data should something happen to the server-based facility.
Confidentiality is a really big concern for our patients, but as well as for our organization. How does somebody beginning to delve into moving from paper charts to electronic charts, what type of considerations are needed for security?
There are some new HIPAA guidelines coming out, and so actually I think that they need to be implemented this month, if I'm correct. And those rules are very clear about what you should and shouldn't be doing with data, but it's pretty dense. We've found in our vendor research that all of the vendor companies have a plan in place to prevent confidentiality from being breached, from data being hacked into. And so it is really key to look at your EHR provider or vendor and make sure that they have an appropriate plan in place, make sure that they are certified like vendor of an EHR system. And with that, I think coordinating closely with your IT department or an IT consultant to ensure that your systems are managing the data appropriately is really key. I mean, one easy example to reference is if a provider is in an exam room with a patient and they open up the medical chart and they're providing patient care, and then they have to step out of the room. Are they shutting down that computer? Is it shutting down automatically? Is it logging out of that health record automatically? There are little details like that that are really important to pay attention to and pretty tricky to implement consistently among your staff.
And so this also makes me wonder about the patient's experience when it comes to the electronic health record. Do you guys ever get feedback from the patients or the clients themselves as to how, it could be partly security, but also how how having electronic health records might affect them?
Jack, do you know, because y'all do the survey, don't you? Jack.
Oh, what survey?
Oh, no, I was
Sorry.
asking. Oh, Jack.
Yeah, sorry, what, Catherine?
Y'all do the surveys, don't you? You give the patient surveys to see how they like if they notice a difference with the electronic health records or anything.
We do a lot of patient spot surveys. I don't think we've asked one specifically about how they think about us being on electronic records, but I think that might be because we've just been doing it for so long at this point.
Yeah.
That, yeah, we'd been on it 2-3 years by the time I even started. So.
Okay.
And there's much movement toward providers communicating with patients through portals within the electronic health record.
Mm-hmm.
I think most systems that are modern and somewhat robust offer a portal so that patients can log in, look at their lab results, and maybe see some other kind of basic health information or message back and forth with their provider. And those are actually standards that are required to meet meaningful use. And so many providers are considering that when they're looking at electronic health records. We have not implemented that component yet because we knew that we were going to be switching from our current health record to another system. We thought it would just be confusing for patients to have different logins.
Yeah.
So we decided just to hold off for a little while.
We've implemented our patient portal at our agency, and so for Meaningful Use Stage 1, you just had to get people signed up for it. But starting in 2014 for Meaningful Use Stage 2, your patients actually have to use it in order to communicate with their doctors and log in and do that kind of stuff. So for the past, since April, May, we've been doing a big visibility drive at the agency to try and get more people to sign up for the portal. And we're seeing a lot of people sign up, but it's really unusual. Like, it's a whole new concept for patients to be logging into a computer to communicate with their providers. So I think it's going to be it's a little tough to get a lot of buy-in from just on the patient level, but it's going to be important moving forward. And the people that use it really enjoy it and like it. It's just a deal of trying to get more people to use it.
And there's an educational component that comes along with that. It's like we have to train our providers to use it and respond, and we also have to train our patients in how to use that software. And a lot of our clients don't necessarily have computers or regular access to the internet, so their comfort with using something like a portal is very limited. And so doing that hands-on, like walking them through that process, I think will be key to successfully doing that implementation.
Yeah, we've seen that putting in-depth directions. Right now, I'm putting together a little flyer that we're going to have in the downstairs in the waiting room of our clinic, explaining step by step how the portal works. Because yeah, it's a lot of instruction needs to be given, and it's tough to give that instruction on that wide of a clinical level.
And a lot of communities that are impacted by HIV are also, in a lot of ways, disparate as part of the digital divide. But however, what we see is catching up is mobile. Are any of these portals available through a mobile platform?
I believe that many of the vendors now are creating mobile applications. Sometimes they cost something additional on top of your normal payment, so that might be a consideration. But I believe the large ones are fully mobile ready, and I think a lot of the physicians almost prefer that as opposed to a computer because they can walk around and stay up to date all while holding their their mobile, either their phone or an iPad. We have not gone that route yet within our clinic, but I could foresee that happening down the road.
Great. I'd like to ask you about coordinating with organizations or pharmacies outside of your organization. How are these partnerships where you are sharing data about a patient set up, and how are they implemented?
Do you guys want to tackle this one first?
Actually, all of our prescriptions go through SureScripts because we do e-prescribing, and so we partner with all of the pharmacies who participate with SureScripts, which is really most of them.
Yeah, we do something very similar. We use SureScripts as well, and so all of our prescriptions go through that system directly to the pharmacy. So whether it's our pharmacy on site or another pharmacy off site, the provider is able to get that prescription over to the pharmacy very easily. I think when you look at integrating services with other entities such as health departments or like from a prevention program to a care program, it gets a little bit more complicated. I know that you guys mentioned that you use Careware as a data system that kind of feeds into your health department because they're your funder and you have to report to them or through them. And I think a lot of Ryan White organizations are using something like Careware. It's still challenging for us when we look at the full kind of spectrum of HIV care, starting with HIV testing to linkage to care to ongoing retention in care. We're often looking at a community-based organization doing the test, that positive individual being sent to the local health department, and from there that person being sent to the clinic. And so there are a lot of opportunities for that individual to get lost along that path. And so what we're working on locally and within Ohio is to share appropriate data. Of course, that typically requires appropriate releases of information and approval by the patient. But we've really tried to disclose appropriate information so that we can have fast services and the data that we need in order to serve that patient quickly.
And I'm sorry, go ahead.
No, go ahead. I was going to say, Jack, you want to talk a little about Beacon? Jack?
Oh.
Okay. Well, we have there's the state of Louisiana and I think the city of New Orleans, and he knows way more about this than I do, but are working on integrating health records with the hospitals and different groups throughout the city so that they can share records. It's been quite challenging, but the people in Jack's department have really done a great job of talking with our software vendor and getting them to adapt the software to accept these interfaces.
Mm-hmm. And I think I can disclose on this webinar, we've selected Epic as our new electronic health record. And part of that decision was based on the fact that nearly all of the local hospital systems in our region use Epic. And,
Epic is awesome.
Yeah, it's a great system. It's very robust. And the fact that they have something called CareWare, which allows providers at any local Epic user site to access records of a shared patient. So if one of our patients is hospitalized over at The Ohio State University, we can look them up in the system, see what's going on, and get more up-to-date information that way.
Yeah, it's really good.
Would the Epic system prevent from case managers having to enter twice or three times to be able to share with their notes, or is that still a challenge? Would that still be a challenge after you move to the new system?
That is still going to be a challenge for us with a particular vendor that we're working with. But with these larger systems like Epic, there are multiple vendors that you can work with that kind of sell the Epic product or sell the next-gen product. And so depending on the vendor's rules and guidelines, you might be able to set up more interfaces that would reduce that data entry.
Great. I think that's a good segue to talk about billing and what is the process of billing? And I want to give you some background on an organization that somebody who I met at the U.S. Conference on AIDS, who doesn't do medical. They're a service organization. They do prevention. They do mostly behavioral prevention, but they also provide HIV testing. And the conversation came up as to whether they were, as a non-medical organization, could they bill insurance for providing HIV testing? And I didn't know the answer to that, and I thought that I might bring that question to you guys and know if you guys had any idea as to whether that's something that a smaller CBO might be able to qualify or certify to be able to bill a third party.
We used to be able to bill Medicaid for case management, but we can't bill Medicaid anymore because the Bayou Health Plan, Medicaid has divided into 5 different plans. And we are not a facility. We are a provider group. We're working on becoming a community health center. It is my understanding that if you are a community health center, you can bill for case management. But you may know more than I do, Anna.
Yeah, we've looked at billing for HIV testing specifically. Currently we offer free HIV testing, and we'll continue to do that.
Yeah, we do too.
Yeah, but we've also looked at in the clinical setting, does it make sense to also offer an option that would bill the individual's insurance for HIV, syphilis, gonorrhea, chlamydia, all of that. And to be honest, I believe that you can bill for those services, even if you're not like a nurse practitioner or physician. But I think it might be based on specific insurance and CMS rules.
It is.
Yeah, and
so we do bill for those services, but just not the case management.
Yeah.
But you're right, it's payer specific.
Yeah, and then the question becomes, is the cost of implementing an electronic health record or billing system worth it? Does it is it cost effective in the end?
Catherine, maybe you can walk us through the process that you went through to be able to help certify your organization to be able to bill third parties.
Well, the first thing you have to do is get your providers credentialed, and there are several different avenues to do that. One is CAQH, which is a provider credentialing website. Usually what I do when I go in is I start from the basics. I get the providers credentialed with Medicare, Medicaid, and Blue Cross. And then once that's all straight, because if you're going to have any issues, it's better to find out when you're just dealing with one insurance payer and not 25. So I usually start out with those three, and then once I have those three, then I put them into CAQH, which most of the commercial carriers use CAQH for their credentialing. And then, of course, once you do that, then getting it all set up in the system, you've got to have the payer ID. If you're going to bill electronically, you've got to have the payer ID. You've got to set up with your clearinghouse which payers you're going to be receiving electronic remittances for, and for us, those electronic remittances come directly into our system. But you've got to make sure you have all your identifying numbers, your group MPI number. All your providers have to have an MPI number, and then you just have to link it all together.
And so what is that? And so for a provider to become certified, what do they? Is there?
What's the what?
What type of problems? What you said that there might be, if there's going to be any problems, what might be some pitfalls which would prevent a provider from becoming certified?
I think that as long as you have all of your information, you have everything current, you have your current license, you have your CLIA waiver. You've got to have, if you're going to start providing services like drawing a lab, you've got to have a CLIA waiver. If you're not, if you have to have a CLIA license if you're actually performing the test, but if you're just doing a venipuncture, you have to have a CLIA waiver. So you just have to make sure you have all of those things in order. I really don't have any problem once what I've done is I have a provider credentialing packet, and excuse me, I get every bit of information up front. I get the Louisiana credentialing application filled out, and then make sure that I have, the references, the work history, and if there's a greater than 3-year gap in any part of the work history, you have to have an explanation. So if you do all that work on the front end and you make sure you have it before you send it in, then it's much easier. And then the other thing that I have found helpful is to find and maintain a contact at each one of the payers. Mm-hmm. So if I have a problem, I have a person I can call instead of just, calling and getting somebody who doesn't know what they're talking about, which happens a lot.
Mm-hmm. On the behavioral health side, I will add that something that we've gone through is the licensure level of our staff really does matter in regards to whether CMS, Medicaid, Medicare, or commercial insurance is going to reimburse you for services. And so we have licensed social workers working for our organization, and essentially how that works is after you achieve your master's degree in social work and you take an independent licensure test and you practice for a certain amount of time, you then qualify for this independent licensure, which means that you can then bill for your mental health or behavioral health services. But until that time, we've had to bill for our social worker services under their supervisor. And so it entails a lot of work on that supervisor's end. They have to review charts, they have to ensure that the patient is receiving appropriate care, and they have to do extensive supervision with a licensed social worker. But it is possible, and I think that a lot of community-based organizations that have behavioral health programs should look at billing for services if they're not already doing it. And if they only have licensed social workers, there is still a way to bill for those services as long as there's an appropriate supervisor in place.
And that credentialing for the behavioral health providers, it takes a lot longer than credentialing for primary care providers. Have you found that to be true?
We have, yeah.
Yeah.
Not sure why, but there's maybe a little bit more scrutiny on their licensure and education.
Anna, you guys also have the added component of a pharmacy. How does billing for a pharmacy differ from, and especially within the electronic health records, from billing in other ways?
Pharmacy is incredibly complicated, and particularly when you have a 340B program, which is kind of a federally run drug discount program. It requires you to keep multiple inventories and very detailed records of the patients that you're serving. So we have two separate systems. We have our pharmacy system, which is called QS1, and then we have our electronic health record system. And they really only interact in the sense that we're sending prescriptions over to our pharmacy, and occasionally our pharmacist will access the health record system to ensure that one of his 340B patients is in fact one of our medical center patients. But for any organization that's considering opening a pharmacy, we've found that working with basically a contract, like accounting entity, helps us manage the billing for pharmacy because it is so complicated and you really could mess up a lot.
Thank you. I wanted to shift focus and talk about disaster planning and how that applies to the electronic health record. And Catherine, being in New Orleans, has the history of disaster with Katrina and just the vulnerability that you have when it comes to weather in that area. Could you give us an idea of what a disaster plan might look like and how it includes the electronic health record?
Jack, are you still on? Poor Jack had a house inspection today. He was calling from his house inspection, so I apologize. Anyway, we have a redundant server that is off-site, and our plan would be, during Katrina, we set up office at our CEO's house and worked out of there, but our plan is that we will be able to access that data and be up and running within a matter of days.
From our organizational perspective, we're actually working on a continuity of operations plan, something that's written down. So we have
that's a great idea.
Yeah, a little bit more guidance because when those crises strike, you're just all over the place.
Yeah.
And having a written plan really does help, especially if it contains the appropriate phone numbers and contacts that you need to reach out to. We've developed agreements with some local organizations that are similar to ours, that if something happened to our buildings or their building, we would have kind of a reciprocal agreement that they could come and use our space and we could come and use their space temporarily. In the Columbus area, we actually have 3 offices, so it's not as much of a concern here. But statewide, I think partnering with other community organizations is a great option if something happens to your site.
Well, and we actually have an agreement with somebody in Shreveport, Louisiana, that if we had another Katrina, we could go there and locate our office there. And we're working towards our accreditation, and I know they're working on getting that that disaster plan really tweaked, where it's the continuity of care plan.
Yeah.
And so the lessons of Katrina, I think, are something that could really help us all. And especially, I remember that right afterwards, we were very concerned about if the city is evacuated, what happens to people who need their medications and that are vulnerable to being lost to care. Is that something that can be remedied in any way with the current systems?
We have these disaster plan, like little informational pamphlets that we give our clients, and we have a website. So we have a number that they can call if they need to get medicine during an emergency. We have, and then we're able to access that information and order their prescriptions for them. We also have a text message service that our clients can opt into if they have a cell phone, where we can text message, if there's an emergency, we can text message them and, give them instructions that way.
Oh, that's fantastic.
Yeah, I'm writing that one down, Catherine.
I know. I'm telling you, it's so good to network.
No, that is very. I love the texting idea. I think at the state level, some coordination should occur, and hopefully planning is occurring at the state level where the ADAPs are being run. Just so that they have a plan, they have a backup pharmacy. The pharmacy knows how it's going to distribute the drugs, and that the state is communicating that plan with the local organizations and providers that interact with patients. Ohio has a plan, but it's not necessarily communicated all that well. So, I think it would be a scramble if something significant happened.
I think it's just a work in progress, because up until 5 years ago, we really, or Katrina, that was longer than that, but we really didn't have disasters of this epic proportion like the flooding in Colorado. And, so I think all of these disaster plans are really still a work, kind of a work in progress. And then this year we didn't have any evacuations in New Orleans. So, last year we had one for Isaac, and it gave us a chance to practice what we had put in place and realize this worked, that didn't work, this worked, that didn't work. So, we just keep on tweaking it a little bit here and there.
2 weeks ago on our last call, we had learned about a provider who was still transitioning to electronic health records when Hurricane Sandy had hit New York and his building was flooded. And what he had done was he'd taken the records and put them in a freezer. All of the paper records, and put them in a freezer so they would be able to salvage them later on and be able to get them into an electronic system.
Well, we do have, thankfully, both of us have our electronic health systems all set up. But one of the things that we found is all the medications that we have on site that have to be refrigerated, and we each take a styrofoam cooler. And, somebody takes some and somebody takes another, and, it's no matter how much you plan, there's always going to be something left over that you realize at the last minute needs to be done.
Yeah, ideally we learn from our best practices and keep moving forward.
Yeah.
And that's why I'm really grateful to have you guys on the line with us today, and for imparting all of your experience and wisdom with us. At this point, I'd like to open up if anybody else has questions, or if you guys have questions of each other.
I don't have any questions, but I'd love to bounce around some of the ideas for the emergency preparedness. I think would be wonderful.
Yeah, that would be great. I'd be happy to make my contact information available.
Yes, I would too, because I think it's just so helpful.
Mm-hmm.
Maybe Eric, can you swap the email addresses?
Absolutely. I'd be happy to.
That would be great. And I'm sorry that we, on our end, have been so disjointed today.
Oh, that's fine. We've had, I think this has been a fantastic discussion, and we all learned a lot. And we hope that we can continue to share this and the reporting of this for others to be able to learn, even those who have electronic health records. But I think we've gotten a lot of really great, valuable information. Is there somebody else who has questions?
This is Anna. I don't have a question, but just as a parting remark, I think there are a lot of great resources online, and the process for selecting an electronic health record is not an easy one, and so it requires a lot of research. The Office of the National Coordinator and their Certification Commission for Healthcare Information Technology provide a lot of information about certified electronic health records that kind of have the stamp of approval. So that can be a really great resource. And I believe that healthit.gov also has some helpful recommendations and links, and helps to get your thought process moving in the right direction about selecting an EHR.
The one thing that I would add about selecting an EHR is, along the lines of what Anna said, is to take your time. And, we did have a lot of demonstrations, but realize that always staying within your budget is, I wish we had stretched a little further, because, we're going to end up having to change our electronic health record as well.
Well, this has been a wonderful discussion. I'd like to thank again Catherine St. Paul and Jack Milloway, who I guess have to step away. You guys have been wonderful. We wish you all the best in New Orleans, as well as Anna Worth in Columbus, Ohio. I hope that you guys enjoyed it as much as we did. And on behalf of Sarah Bowie, who is on the chat feature, and myself, Eric Valera, I want to thank you guys and everybody who's participated in this call.
All right. Thank you so much. And Anna, I'll look forward to connecting with you at some point soon.
Absolutely.
Okay.
And take care.
Have a great afternoon.
All right. Bye-bye.
Bye-bye.
Thank you. Please stand by.